let's get on with the topic of today's talk, which is a trip I took earlier this year. So MB is a great employer and offers a grant, which is called a Development Fund grant, and you can apply for that. And I was lucky enough last year to be awarded that grant, and it's really to give people the opportunity to do learning or training which is perhaps not usually available. And what I proposed was that I do a bit of a study trip to the UK to learn from the experiences there with social services, procurement and commissioning, and bring it back and share it. So I'm now carrying out my obligation to share. But it's been really good to prepare this talk because it's given me the opportunity to go back over those great discussions I had and to look at new material which has been issued even since I was in the UK, and to come and talk to you about it. And at the end of the talk, it'll be great to hear your questions and perhaps get your thoughts on some of the things that I've seen. So the objectives of the trip and what I put in my application for the development grant was to identify what's worked there to strengthen capability in social services, procurement, commissioning and engaging with community and social services providers. I was quite interested in what's happening with the large local authorities in England, where you probably know they manage all of the social care services over there. I was aware of specific initiatives like the Government Outcomes Lab, which I'll tell you a little about. And Scotland really appealed because it has some of New Zealand's challenges of a small population and a relatively widely spread geographically. I'd also read a paper from Wales that suggested that they were looking at moving away from outsourcing, and I was a bit curious to understand what that would mean if they moved away, and would it mean more in-house provision. So you can see it was quite a wide ambit, and in fact I found when I was preparing for today that I had simply too much information. So I've had to choose an area to focus on today, which is Scotland, my Scottish visits, so I'll tell you a bit more about that. But what I have done about the rest of my trip is I've prepared a resource with interesting links, which we'll share with you with the slides after today. So I got the opportunity to spend 3 weeks in the UK, and so where did I go? Well, there had to be one photograph of me. I feel like this calls for a little joke, and the best I could think of was, one of these is the Queen of all she surveys, and the other has been dead for more than 100 years. Do you proud, Andrew?
Yeah, really good.
So I obviously went to England, and my first visit was to the Government Outcomes Lab at the School of Government at Oxford. Now, I was a little bit nervous for my first visit, so I didn't actually take a photograph of the building I was going to at Oxford, but this is Christchurch College, which is amazingly beautiful. And what I went there to talk about was the work they're doing around outcomes contracting and social impact bonds, and work about collaboration and raising capability. So links will be shared to that. I think there's some really interesting stuff there. They've got some good guidance if you're interested in that. I then attended a conference at the King's Fund where the topic was population health. But what I was really interested in there was hearing from some of the larger local authorities. My attempts to arrange meetings with large local authorities directly had not been that successful because they're quite busy, surprisingly. So a conference was a good place to hear from several of them. And particularly interesting at this conference was the discussion from Wigan about the Wigan deal, and also some information from the Greater London Authority. Again, links to be shared. I visited Wales. This is, I think, the town hall in Cardiff. And what I found there was that they're in a real state of change. So they have 2 bodies which carry out the functions equivalent to NZGP. They have the National Procurement Service, which manages their all-of-government contracts, or framework contracts as they call them, and they have Value Wales, which does the capability piece. And they've really found that with their all-of-government contracts, they've gone too big. They've found that they have too many framework contracts to manage, and in fact they weren't being picked up to the extent that they thought. So that has led to a reconsideration of the structure. And when I was there, with that and reforms for social services, they were at a point where they'd identified some issues and knew they needed to change things, but they hadn't yet made decisions, or not made decisions which they could tell me about. So it was kind of an awkward time to be a visitor, hearing about things which weren't quite right and which they hoped to change. They've got some interesting legislation there. They've got their Public Services Social Value Act, which is really interesting to compare what they're doing, because that's their broader outcomes legislation. They say they were the first in the world to do that by legislation, so an interesting example for you. They also have the Social Services and Wellbeing Act, which provides for partnership and cooperation to drive social services delivery. And you'll hear this theme as I talk today, using legislation as the lever to achieve things which we probably wouldn't use legislation for. And I would argue that's probably for New Zealand right, that we don't use legislation. So in Wales, they've also got partnership boards which are trying to integrate social services and health services, and they've got a national outcomes framework. So there's some interesting information in the links. I think that national outcomes framework is probably quite interesting if we think about Treasury's wellbeing, living standards, and what can be done in different jurisdictions around that. And then I went up to Scotland, where I spent about a week and met a whole lot of people. Here we are in Edinburgh. Oops. Just off the Royal Mile, as I wandered around meeting people. And I also took some leave while I was up there in Scotland, and here we are up in the Highlands. And of course, no trip to Scotland would be complete without a picture of Nessie. So you'll see that all of my photographs are of scenery, and probably a different kind of person would have taken a lot of photographs of herself and the people she met. I found that really awkward, because most of the time I was meeting one-on-one, it would have had to be a selfie, and I couldn't work out quite how to ask. So instead you get photographs of scenery. Okay, so what was I interested in Scotland? The thing that particularly interested me was the efforts which they're making to integrate their health services and their adult social care. So Scotland, like I said, small population, some in remote areas, and they've passed legislation called the Public Bodies Joint Working Scotland Act back in 2014, and that's to drive that integration. So over there they've got the NHS, which does the health services, and they've got the local authorities which do the social services. I haven't looked into this deeply, but I'm wondering if perhaps the reason that they've had to use legislation is because that's how to regulate the local authorities, and things like cabinet decisions might not do the trick in that situation. So let me talk a little bit about integration, and then I'll tell you about the people that I met and the things that they had to say about their progress with integration and the effect on services and on commissioning and procurement of services. So they passed the Act in 2014, and the Act requires the local authority and the NHS to set up an integration joint board, and each joint board has a chief officer who's a pivotal role. The scope of services included under the integration joint boards is adult social care, which is care for older adults and people with disabilities, plus the health care for those people. the Integration Board can voluntarily add other services, such as services for children or housing related services, and some of the integration joint boards have chosen to do that. And the purpose of this change was to ensure that people have access to services and high levels of support. It drives redesign of services where necessary to provide seamless support for people, and they're hoping to achieve a focus on prevention, quality and sustainability. A further purpose of the change, an explicit purpose, is around relationships and open collaborative partnerships with the provider sector. Each of the integration joint boards is required to publish a strategic commissioning plan every 3 years. So they've published one, and they're just in the cycle of publishing their second one. In 2018, Audit Scotland published a review of progress with integration, and that review was not wholly positive, and here's one of the things that they had to say. While some improvements have been made to the delivery of health and social care services, integration authorities, councils and NHS boards need to show a stronger commitment to collaborative working to achieve the real long-term benefits of an integrated system. They found the particular challenges were around joined-up financial planning, governance, strategic planning and leadership capability. There were problems and delays in setting the budgets for the integrated joint boards, and legislative budget arrangements still had to be fully implemented. And you can imagine that without good budget arrangements, it's quite difficult to make progress. They also found that there'd been quite a high turnover rate with those chief officers, and this was the subject of some discussion as I went round and met with people. When I was at the King's Fund, I had the opportunity to meet with a researcher there, and I asked him about my perception that there had been greater progress with integration in Scotland rather than in the UK, and I had asked him whether he thought that the legislation was part of it. His view was that it was much easier to impose one model across Scotland than it would be to impose one particular model across the local authorities, which have a much greater scope and authority, and there's been some devolution of funding and decision making to local authorities. Scotland apparently also has a wider eligibility and more generous access for social care, which made it easier to integrate, but he did say that there's no evidence yet in terms of measures that integration has improved services. And he talked about, this seems to be a measure used a great deal in social services or health services in the UK, delayed discharge. So the longer that people wait to be discharged from hospital is a useful measure of, I guess, treatment and support for them. So that is a big reform happening in Scotland, but that's not all that's happening. They're also implementing legislation for self-directed support for adults. They've got a reform of adult social care happening, which is looking to take a human rights approach, and they've implemented health and social care standards, which mean that a lot of the service specification has been replaced. So that's a huge amount of change happening in a relatively small government at one time. An interesting thing I observed on the various reports about all these changes was that the partners in reform were often from the provider sector. So in the various government reports, it would often be a government report with a social sector umbrella group or a health related umbrella group, which I thought was interesting that they were participating so directly in the reviews and implementation processes. So who did I meet in Scotland? Well, I met people with a range of different perspectives, and this was really useful. So first of all, Scottish Care, a large umbrella group for care providers. I met with the head of the social care reform program from the Scottish Government. I travelled out to a small local authority on the Scottish borders. I went to see Scotland Excel, which is the equivalent of NZGP, and I met with policy officials who'd been responsible for the legislation back in 2014 and who now were responsible for advising ministers following on from the audit report and dealing with recommendations for change. So you can see that kind of gave me the 360 around the proposals, and I mean not the proposals, the legislation and how the implementation is going. And it was also great because maybe because I was coming from far away and would never probably meet with any of them again, they were quite happy to talk about each other. So Scottish Care was the first group I met, and I met with Donna McAskill, the Chief Executive, and Karen Hedge, the National Director. Their view was that the implementation doesn't yet meet the objectives of the Act. They feel like the two systems are starting to get to know each other. The view of the Chief Executive, his first comment to me was that the legislation had made not one bit of difference, which I don't fully accept. And in fact, his comments went on to talk about some of the differences that had been made by the legislation. So he felt that yes, legislation had forced attention to collaboration. He felt that health was still the dominant voice in the integration between health and social services, and this was echoed by others as well. The intended focus on prevention hasn't yet happened. He and a few others who I met had quite a bit to say about procurement, and some of this is going to sound familiar to us. So, I liked this quote, too many procurement staff are specialists in paper clips. Procurement people are too driven by process and afraid to support innovation. Just a small pause here for explanation. The procurement process in the UK is, as we speak, still driven by the EU rules, and the light touch regime, which enables more flexibility for social and health services, has only been in place for a limited time. I'm feeling a little bit nervous that there are some people from the UK in the audience who know this stuff better than I do, so pipe up if I'm getting it wrong. So there is this light touch regime, and several people expressed to me the view that procurement people were a bit nervous to use the light touch regime, which provides this greater flexibility, because they felt that their processes were still subject to challenge. And they also didn't really know how to use that discretion. Following on from the publication or the enactment of the legislation, there's been a lot of guidance published, Scottish Care said, and also Scottish Care alerted me to the fact that Scotland Excel, the equivalent of NZGP, has a role in creating framework agreements around social care, which is quite a contrast with New Zealand, and I was interested to talk about that. The care sector and the Scottish Care and the care sector have been working with Scotland Excel, partly around costing care homes. That was a really interesting discussion. They had got a long way in agreeing basic costing frameworks, but as you'd expect, the places which they hadn't been able to agree on was what level of profit was reasonable and what should be the return on capital. But of course, that would be the two places where you wouldn't agree. Also interesting was a bit of a discussion around the philosophy of profit making in the care sector. I hadn't come across this before, but apparently there is a strong view amongst some in Scotland that making any profit at all out of social care is unacceptable. The group Social Care talked about the need for greater collaboration, and that's the space which they see things needing to move in. They believe, as I guess lots of us do too, that collaboration gives opportunities for greater creativity. They wanted to see a move away from competitive approaches to care being delivered in a geographical area by local-based providers, and they wanted to see the reduction of duplication and information sharing to reduce duplication, and I know that'll be familiar to us as well. So next I met with Lorna Ashcroft, who was a policy official responsible for leading the work on the social care reform. She also agreed that integration depends on adoption. She was more positive. She believes that the change will start to accelerate in the next 2 years, and for reasons I'll come to, I've got some sympathy with those views. Again, some talk about procurement. So strategic commissioning can be derailed by competitive procurement processes. The legislation and guidance is there, but the practice is slower to change. And Lorna was seeing still in the sector a lack of transparency around funding models, short-term contracts, and over-specification. And again, those are issues we hear about, so what is happening in Scotland? Well, they're shifting contracting to support self-directed support, and we have some equivalencies in the health sector here in New Zealand. As a result of integration, she thinks that the assessments people go through for care are more broadly focused on health and care services. And she also spoke about the reform of adult social care, which, as I've already mentioned, has been developed with sector partners so that they have come up with a shared vision of adult social care, and I'll share the links with you about that. And you'll see there that the input of the sector partners is acknowledged. The guidance has been very important. Lorna Ashcroft thought to give people confidence to operate in a way that's not driven by risk and dollars. Not everything is fixed, and she also had concerns about the focus on delayed discharge as a measure to drive outcomes. Now, my visit to Scotland Excel, the equivalent to NZGP, was really interesting. So I've got a couple of slides on this, and I would recommend anybody who's interested go to their website and have a look at their material. So like us, they carry out both the procurement and the capability functions, and I did touch base with them around their capability functions, but today we're just going to talk about how they manage the social care framework agreements. So those are created by and for local authorities. And at that time, the category manager for social care, Edmund Mackay, was examining a national procurement solution for care and support services. And there had been in place for quite some time framework agreements for children or youth services, and one for rest homes or care for the elderly. That national procurement solution for care and support services was running up towards their tender, and I just checked yesterday, and their tender is now open. And as an example that you can't plan for everything, the time for responding to the tender has been extended because the government has made announcements about the living wage. So here's a process that has been going on, I think, for at least 2 years planning for this, and they must have known that there was a possibility of the living wage announcements coming and had to make a decision about whether to go out to tender or wait for the announcement, and this is just what happens in life, right? I heard a little bit of commentary on Scotland Excel from one of the local authorities that I met. The view was that when Scotland Excel first started to work in social care, they were perhaps a little naive. They observed that costs for social care had climbed, and the person I was speaking to said from Scotland Excel there was a bit of an attitude of leave it to the professionals, we'll fix this. But now the view is that with experience, Scotland Excel is shifting towards getting services commissioned and working in partnership with the sector. So the local authorities who are working with Scotland Excel are seeing a change in their approach, perhaps shifting from paper clips more into the social services approach. So what I'm quite curious about is whether there are any opportunities in New Zealand, or whether there would be benefits in New Zealand for doing framework agreements or all of government agreements or part of government agreements around any of the social services. I don't know the answer to that, but I'd be keen to hear people's views. So one of the interesting documents on the Scotland Excel website, and a bit of the discussion that we had, was around the procurement strategy for care and support. So this is care and support for older people and adults with learning disabilities, not necessarily, so it will be care in their homes. The strategy was created as part of a consultative process, and I thought it was a really useful document for setting out, firstly, all of the context, which is complex because, as we've already talked about, there's a lot of change. It looks at the provider sector, who they are, the spend, and who might purchase from the contract. It looked at the national outcomes and how this agreement might contribute to that. And it looks at the opportunities for community benefits and fair work, so some analogies there for our broader outcomes. And it extensively covers how they determined the procurement route, which I thought was quite a useful discussion for the provider sector to understand why they had chosen to go down, in this case, competitive route. They'd looked at alliancing but decided against it, and they decided against, I think, direct procurement as well. It also set out the timeline and how they were going to manage the framework agreement once it was in place. Now, that kind of procurement strategy probably quite familiar to us in the commercial space or as an internal document, but I thought this being published well ahead of the tender process was a great piece of transparency, and I just wondered if we might do more of this. In my discussions with provider umbrella groups, I've heard them both say, why did this go out to a competitive process? And I've heard them say, why didn't it go out to competitive process? Our providers were expecting they'd have a chance to bid on this contract. So publishing the reasoning for that might help with some of that transparency and communication. The other aspect of the procurement strategy, which I thought was quite an achievement, was that they've managed to boil it all down to 34 pages of quite clear explanation, which for a pretty complex contract and complex sector was a good effort, and probably what you should aim at when you're doing a strategy, but it's hard to write short things. I then went out to the Scottish Borders Council. So what I was interested in here was an actual live example of integration between the local authority and the NHS. And I got on a train at Edinburgh Station and went out to a small rural area. I'd made an arrangement that I would be picked up from the station by the person I was going to meet. And as I was walking along the station platform, my mother's voice was in my ear, "Justine, are you going to get in the car with a stranger?" But here I am, so it was all fine. The Borders Council has 115,000, so quite a small population over a large rural area. they have some challenges which are unlike anything that we would experience. Just for a small example, their care homes are often in old manors and are becoming unsuitable for purpose, and I guess isolated where you want to put a manor rather than necessarily where you want to be in a community. So that's one thing we don't have to deal with. So they're trying to think about how they change their service provision for older adults or people with dementia into more specialised at home for longer care. So I met Eric Livingston, who's the business manager for social care, and Michael Murphy, who's the interim head of adult care. So they're both on the local authority side. And their integrated joint board doesn't directly provide any services. So the council still looks after the social care and the NHS still looks after health, and nor is the budget joined up. And they described to me the problems about getting an agreed budget, and it's really delayed year on year. And that was one of the recommendations coming back from the government as well, that budget process had to be fixed. The board creates the integration strategic plan and commissions services, but doesn't deliver. And here are some of the things which we talked about. Collaborative working was described as a strength of the borders, which in a small rural community you can imagine very similar to New Zealand. The main challenges they described were that one around budgets and decision making and balancing between health and care. So again, they felt that health, I guess probably the bigger budget and more evidence-based, was still dominating the integration, and the measures were mainly around health measures. Two of the three measures at a national level are health measures. They describe some quite useful successes with their care for older people around that continuum of care, and this was around getting the NHS nursing staff to come out of the hospital and go into the community more and provide a range of different care. There are real workforce challenges in a small rural area with people not wanting to necessarily move there, and they also describe some challenges with, I guess, health and safety legislation equivalent. So a helpful neighbour might not be so welcome in terms of triggering health and safety, or maybe not complying with the health and care standards. So what they would like to do is take an asset-based approach, which they described to me, takes account of all the existing support that the person has, but sometimes there are barriers in the way of taking account of some of that support, which seems a bit of a pity when you're looking to build community support and collaboration. He also described the procurement and competitive overlay as not always helpful, and people being uncertain about using that light touch regime. And then at the end, I met a couple of policy officials who were quite positive and hopeful about what the next few years will bring. They explained to me, which I hadn't realised, that there was quite a long history of legislation in this area. They, based on the audit report and the recommendations of the government review, felt that the legislation was about right, and this was evidenced by the fact that the recommendations are all around behaviour and culture. The reason they were so hopeful and positive about the future was that this approach of integrating social care and health care has now got broad-based political support. So they felt that people who might have been dragging their feet in hopes of a change of government would now not be able to hide from the need to change. They felt quite hopeful that we'd see big change in the next set of strategic commissioning plans, and there's certainly lots of support around those integrated joint boards and developing their plans. They said there was a need to educate procurement people around collaborating and strategic commissioning. And they also referred me to some better examples of integrated planning, which you might like to look at. So here are some conclusions, and this is where I'd be grateful for your thoughts or any knowledge you may have. The legislation has meant that the local authorities and the NHS have to give at least lip service and forced attention on the need to collaborate. But behaviour change is the real game. I feel like this is probably true of all large changes, and you'll have experienced some of this in your own work career. Procurement needs to be part of the team, and I think perhaps the situation here in New Zealand is a little bit different from Scotland. I feel like we do have a group of procurement professionals who do know the social care sector well, or do know what's different about procuring social services as opposed to paper clips. And sometimes I think that our challenge is more getting our policy officials to engage with us early enough to give us the opportunity to create those innovative approaches. Sometimes if people come to us too late, we have no option but to offer them the quick, familiar process, and we don't get to craft something for them. So I think there's probably a bit of an obligation on us to be engaging out with policy people to tell them what we can do if they would give us the chance. And also what they can do during the procurement process to build on the collaborative, consultative approaches which they're trying to create during the policy process, so that those outcomes and objectives flow through during the procurement process. The continued scrutiny from Audit Scotland and the government reviews has been helpful in identifying the changes. I thought that actually 3 years to bring about this level of change was where they got to, felt to me like actually about where you'd expect things to be. The boards have been set up, they've done their first set of strategic commissioning plans, and they've tried some new things. I just felt that it's likely to take a bit more time than 3 years to get that level of behaviour change. Maybe I'm wrong. So what resonates for New Zealand? Well, it's that ageing population and complexity, the desire to have better outcomes for people. I've put here that there was a theme around Indigenous culture and rights. Now it's different from New Zealand, but going to Wales and Scotland and Ireland, as I did when I was on leave, you'd have to be blind not to notice that there's still some feelings about England. And in Wales particularly, they're looking to reclaim their language. So there were all of the public announcements and documents are in both Welsh and in English. And I overheard on the train platform some of the same discussions which I've heard in New Zealand about why are we supporting a dead language? This is pointless. Only 3 of us are ever going to be able to speak it. Some real parallels there, but also a feeling of positivity. I think they have immersion kindergartens for children, similar to Kohangareo there. So a real effort to rebuild Indigenous Welsh culture. Relationships with providers. So I heard over there, as I hear a lot in New Zealand, the word partnership used and the aspiration to achieve partnership with the sector. And also what resonated for me was around procurement and this wrestling with how we safely and clearly and transparently use our discretion to craft procurement approaches around social services. So I can't finish my talk without acknowledging all of the people who took time to meet with me. People were really generous with their time and their knowledge and their expertise, and pointed me to a lot of good guidance. That was one of my key takeaways from the visit, that the UK doesn't necessarily have all the answers. I probably knew that before I went over there, right? But they are trying so many different things, and they have the scale to try so many different things. So almost everything we can think of or want to try, there's an example of over there, and there's usually some good, clear guidance. So I think that's where we can learn most from there. I need to express my thanks to MB as my employer for offering this fantastic grant and opportunity, and maybe some of you will think about coming to work at MB. Thanks to my managers who supported my application, Mark Richards, who's now at MFAT, John Ivell, our General Manager, and Margaret Pearson, who was my acting manager while I was away. And of course, thanks to my lovely team, Ray and Cole, who held the fort, and all of Capability Services, our team. So any questions for me or any thoughts? Hi, Connie.
Hi, Justine, I may have got it entirely wrong, but it sounded very individualistic to me. We've got a very whānau-based approach to services here. Is that a real difference over there?
I suspect it probably is. I think we're probably still getting to grips with what it means to provide services in a whānau way, probably because we're bringing our, well, I should speak for myself, right, Pākehā individualistic approach, which I suspect we're bringing over. I wonder if some of the cultures who have come to live in the UK have more of that family-based collective approach though, so I don't fully know the answer, but I certainly didn't hear anything that was similar to whānau-based or family-based support. Yeah. Andrew?
With the budgets, you've got the NHS and you've got the new board.
Yeah.
Have they got more money now, or do they just got to split up what they've got differently?
No, you're right, they seem not to have more money. In fact, I think they have to achieve savings, the idea being that they drive some duplication out of the system, etc. And one of the challenges for the NHS in particular is to kind of unpick this slice of money from over here and put it together with those social care funding, and similar challenge on the local authority side, I imagine, but not quite so complex. Come back.
Justine, what a fantastic trip and such rich information you brought back. It's
almost
wonderful.
Too much.
Yeah. I'm looking forward to seeing more. I just had one question, which is around the National Outcomes Framework in Wales and also Scotland. So you talked about the measurement of the successes of the framework. Where's the data coming? What kind of data are they using? Is it quantitative and qualitative? Can you talk a bit about that, please?
Yeah, I can't, to be honest, but that's okay. That's okay. There was going to be one question I couldn't answer, but it would be good to have a look at that. And I assume since they've got a national outcomes framework, they're perhaps more advanced around the measures as well. Maybe somebody here knows the answer. Something for us to look at.
Hi. Okay. Are they commissioning joint services, so one service provider that provides a service that is both health and social care, or is it still separate at the point of delivery?
Yeah, it's definitely intended to be a seamless care experience, so a package of support for the person. I think that probably the findings of the audit report is that that has not yet fully happened, but some experiences or experiments have happened. One of the examples that was spoken about was an alliance and commissioning around the homeless in one of the other Scottish local authority regions, where they felt that had been a great example. So I think there are probably examples of that starting to happen, but that's the behaviour change that they're trying to achieve, which is not yet embedded. I would have liked to perhaps gone to more than just one local authority, but there's only so much you can get around.
As soon as I'm holding the mic,
Carry the mic.
So you talked about the disparity in power influence whatever between the NHS and the local authorities. But from memory of when I used to live there, social services is the dominant part of any local authority's budget as well.
Yeah.
So you've got that power disparity as well. So
Yes.
I'm wondering, have they devolved the whole of the adult social care budget to the partnership, and then if they have, then the partnership's going to become dominant versus the residual local authority? Like, is there a tension there?
Possibly, in that the chief officer is not employed by the local authority or the NHS. That seems like a reasonable comment, but I don't know.
Thank you.
Just around the boards, you talked about just being the budgeting for joint boards, the budget problems. Did you get any information about what kinds of problems they were experiencing?
It was the process of setting the budgets for the boards, which was delayed, and there is a legislative process around the budget for the boards or the joint services, and Audit Scotland found that had not been fully implemented. And the challenges that Audit Scotland describes were in things like governance and leadership and turnover in the chief officers. So you can see there's a big challenges in the structure and governance, which will naturally flow down into the implementation of behaviour. So they're in a situation where they've got the legislation, they've got lots of good guidance, so they've got pointing people in the right direction, and in the next 3 years hope to see more of that behaviour change, which with strong political support, the policy people at least feel there's a good chance of that happening now. Question over here from Joe.
You talked at the start about some of the views around whether providers should be making a profit, and I know that particularly in the health space, there's a lot more for-profit organisations that work, particularly in the aged care sector. Do you see many parallels with the similar debates that are going on in New Zealand about fair funding and actually allowing people to have a little bit of a profit on the top so that they can reinvest?
I do. I sometimes hear a misunderstanding that not-for-profit means you're not allowed to make a profit because you're a charitable organisation. But in fact, if a charitable organisation is to carry out their own objectives, in addition to the purchased outcomes purchased from government, then they presumably need a little bit above cost. I haven't heard discussions about how much is appropriate or how that is determined. Did I tiptoe through that carefully enough?
Hi. What is it?
Yeah, it should be.
What is it about strategic commissioning that we need to learn? Is there some different contexts, obviously, but are there crossovers and things we need to be doing here, maybe?
Yeah, I'm still struggling with thinking about this a little, so I haven't talked much about it today. But although we talk about commissioning a lot, I'm not sure that we have fully adopted or implemented a consistent commissioning model. And I'm not sure why that is. The UK has, and Australia has to a certain extent. And I know there are examples of commissioning thinking, but it's not consistent. And I'm not speaking entirely on a base of just my own opinion. The Productivity Commission found the same. I'm not sure why we're not doing it in New Zealand. I'm not sure what commissioning would offer that's different that we're not doing now. Like, what is the benefit to be had from adopting a commissioning approach in New Zealand? I suspect it's this question of the link between policy and procurement people, so that policy people see procurement as part of a bigger process than just doing the policy proposal and implementing it. That's my suspicion, that there's a potential for commissioning thinking to improve our practice by better linking us up with policy people and getting them to come and talk to us earlier, effectively. But does anybody else have thoughts on that? I'm really curious.
Could it be that what you're talking about here is local government being affected by a central government, and there seems to be more of a split, or they're not as joined up here?
Right.
You know, so that's effectively what you've been talking about, is a central government edict has now affected, in a very real way, local government right down to the who sits where sort of thing. And that wouldn't happen here at the moment, would it?
Well, it could happen, not through legislation, but through other means, and maybe some kind of edict is what we need across sector one if we're going to adopt commissioning approaches. But I can see people need to go, so I'll stop there and thank you all very much for coming in.